name is Benjamin Diamond. I'm an assistant professor over at the University of Miami. I'm a physician scientist, and we'll be talking today about one of the clinical trials we've run together. So this was a phase 2 single-arm study for relapsed refractory multiple myeloma, specifically for patients that have had 1 to 3 prior lines of therapy, so early relapse. And we targeted patients that were lenalidomide refractory. And the reason we did this is because in the second or so line setting, most patients become lenalidomide refractory in this disease. And the treatments that we have offer comparatively poor outcomes compared to some of the emerging therapies that are often offered in more late line settings. So this is a quadruplet regimen that we prepared with a backbone of Iberdomide, which is a novel CELMoD, a cereblon E3 ligase modulator, with the intent to try to rescue patients from that lenalidomide or IMiD refractoriness. And with the quadruplet backbone, the idea was to drive MRD negative responses, to recapture a nice deep response, and afford the patient the opportunity to de-escalate their therapy back down to monotherapy and restore the good quality of life. So this was a 32-patient single-arm study. And patients who were eligible enrolled to receive 8 28-day cycles of Iberdomide, carfilzomib, daratumumab, and dexamethasone. Iberdomide was the starting dose of 1 milligram. And then at the end of those 8 cycles of reinduction therapy, so to speak, patients underwent a bone marrow biopsy. We did MRD testing via either adaptive clonoSEQ, which is next generation sequencing, test versus multiparametric flow cytometry. And that was the primary endpoint, to achieve MRD negativity at 10 to the negative fifth at the end of those 8 cycles of therapy. Now, regardless of the response, though, all patients would then de-escalate to Iberdomide monotherapy for up to 36 cycles or 3 years. And to give you a little bit of a background, in this setting for patients with lenalidomide refractoriness using triplet regimens, which are sort of the standard of care, the rates of MRD negativity are around 10 to 20%. So for our primary endpoint, we had 24 evaluable patients at the time of the data cutoff. The rate was 71%. Which is substantially higher than what we've seen in the past. Some of the other things that you might be interested in are safety. And so this is the first time these drugs are all used together in a combination therapy. And sort of as expected, we saw a decent amount of hematologic toxicity. Now, this is stuff patients obviously aren't feeling, but we worry about infection with neutropenia rates. So what we did see was that in the first 2 cycles, the neutropenia rates were pretty high. We supported patients with growth factor. And we didn't see any increase in infections related to that neutropenia in the first couple of cycles. And despite the neutropenia, we were able to maintain a 90% relative dose intensity of Iberdomide. There were some non-hematologic adverse events. We had one patient that did have to come off study for previously undiagnosed coronary artery disease, had a heart attack on the study, unfortunately. But aside from that, no new safety signals. And patients tolerated the therapy quite well. So the conclusion is that, Iberdomide does seem to be a very potent agent for lenalidomide refractory patients. And the drug is hopefully soon to be approved in some other combinations based on the results of Excalibur, RRMM, and a couple of other studies that are ongoing. So I think that you should very much look out for CELMoDs, specifically Iberdomide, in combination with proteasome inhibitors and also with CD38 antibodies as a really viable option for patients in the early relapse setting.